who are arthritic, especially rheumatoid arthritis. But that's one of the things you see. Arthritis doesn't just affect your joints unless it's osteo. But if it's rheumatoid, it affects other things in your body as well. So dry eye syndrome, severely dry, where the patients not only just need drops, sometimes they need tear duct plugs, sometimes they need to be put on some of the other medications. Thinking about the thing, it's actually a chemo drug that they actually use to do eye drops. Restasis. I can't think of what the name of the drug was. All right, but that's cyclosporin, ophthalmic solution. So if you get, that's not just the regular stuff is going to work that they use over the counter. You usually have to get into prescription medications to treat the dry eyes that they have. Now the bad part about that is when your eyes are very dry, it can affect your vision. Okay, so that's something that's, if people have it, they really know the difference when you're not getting the drops that you need to have. So they end up with other things that are going on. Not only do they hurt, now I can't see. So different things can happen with your patient. But that is one of the things that you see associated with it on both sides. Okay. The other commonality they have is things with skin. So you can see patients that actually develop psoriasis. They can have lesions on their skin. We don't really know why it happens, but it's part of that autoimmune things that happens with your patients. You can see all of that kind of going on together. The other piece of that is joint. So the commonality is that you can have patients who develop rheumatoid arthritis. Okay, they can have joint deformities that go along with that. So not only do they have this abdominal pain, they have pain when they're getting up, moving around. And you know rheumatoid patients have to kind of warm up as the day goes on and they feel a little better. But one of those things is that, you know, you have to give them medications to decrease that as well. So that's why a lot more patients are not just doing steroids, they're doing some of the other drugs that we're going to talk about associated with that. Okay. Now this patient has diarrhea, we know that was common, right? Because that's one of the commonalities. But it's rare for a patient who has Crohn's to have bloody diarrhea. That's one of the things that makes it different. The time that you see a person that actually has bloody diarrhea is because there's a perforation, a fistula, or something like that that has happened. It's not the common thing that you see when a person has Crohn's. Yes, they have a lot of stools, because they can have a lot of them during the day. 6, 10, 12, depends on how bad the flare-up is. But they don't usually have bloody diarrhea unless there's something actively going on. So perforation, fistula, something like that is causing the problem in the patient. Crohn's patients are also people who we do not treat with surgery unless we absolutely have to. And you would think, oh, if you got this problem going on, I can do surgery and cut it out. But remember, with this person, it jumps around. So I may have to cut out a lot of bowel, and you do have a lot, which is a good thing. But just because I anastomose the area today doesn't mean that place is not going to be diseased the next week. So that you save surgery only for patients who absolutely need it. Because if you cut them, that way you'll be cutting every few weeks, sometimes depending on how bad their Crohn's disease is. And then you run out of bowel. So what are you going to do? It's not a good thing. Okay, so you do ostomies. A lot of them, there's a girl that sometimes comes and talks to the students I have sometimes at UT, that she created her own line of covers for ostomy bags. So that's how she goes out and talks to patients about their ostomy, because she's an ambassador for one of the companies that does it, you know, does the devices. And then she came out with an actual line of things to cover ostomies. So people don't feel like, you know, because that's not a pleasant thing when you're thinking about, I have stool coming out of my side. You know, sometimes patients will say it in the worst way, not just stool coming out of their side. They're not happy, and you understand that. It's a body image kind of issue that you have with this patient. And especially, we talked about the age group. Think about a teenager who now has an ostomy. Or somebody who's 20 years old, when you're developing your relationships or you're trying to be intimate with somebody and that's what you're thinking about, is my bag going to open? You know, those are things that hopefully people don't have to think about, but because of this disease, they do. So a lot of psychological kind of stuff is going to be on both sides, but especially for Crohn's patients. So then we get to ulcerative colitis. Okay? And I should tell you, the most common place where Crohn's does happen, even though it can happen everywhere, is the terminal ileum. That's where it happens most often. But it can happen anywhere along the GI tract. When we get to ulcerative colitis, it only happens in one spot, that's the colon. So for this particular person, if it was really, really bad, curative would be to actually just take it out. But that's never going to be the first line treatment they do. They're going to treat it symptomatically first. Now with this particular disorder, you actually have ulceration in the mucosa of the GI tract. So this person has bloody diarrhea frequently. Okay, remember how the person had it rare in Crohn's? It's part of the process when you're talking about a patient who has ulcerative colitis. And if you just think of the name, ulcers, bleeding, you think about what the patient has. Okay, so bloody diarrhea is common for ulcerative colitis patients. It is an inflammatory response, so what I want to do is give the patient steroids, and sometimes you give them a lot, because you're not talking, you got to get this process under control with the patient. So you're going to give them large dose steroids, and sometimes that remedies the problem. Patients go into remission and never have another issue that has that. But always remember, the thing you always have to think about with steroids, steroids are fantastic drugs and they do great things, but they are not without cost. And not sometimes just for the short term. You're talking about long-term things that happen with your patients because of it. Okay. Patient may do fine for a couple of years, and then all of a sudden they start having pain in the hip, pain in the shoulder, and you're thinking, what's going on? One of the things that is you see sometimes with really high-dose steroids, like you have to do with these disorders, patients can end up with avascular necrosis in the joints. And so that sometimes they'll end up having to have hip replacement. Sometimes they have to have rotator cuff surgery, all this kind of crazy stuff. And you try to figure out why did it happen. It goes back to large amounts of steroids to treat their disease process. So just know, it's not like it's something that you want to keep a person off for a long time, but the thing about it is it works wonders for doing what it does, but you may have to deal with it for a long time. So just know that that sometimes happens. We actually had somebody who used to work with us that happened. She had ulcerative colitis, was treated in the hospital, went home, and probably 3 years later had to have hip surgery, one of our adjunct faculty. And that was something, she got her disease treated, she did well with that, but then she ended up having, when they told her what she had, she was like, how did I get this? And that's what they traced it back to, was because she had to do high-dose steroid therapy for her ulcerative colitis. So sometimes bad things happen even though you get a good result for what you're doing at that particular time. But bloody diarrhea is common on this side, so that makes it different because we didn't see that unless something is going on with the patient who has Crohn's disease. Now the thing about it is you're talking about where these areas, you talk about the intestinal tract. So then you think about what are those, some of the other things I'm going to see as far as signs and symptoms assessment with my patient. They're going to have poor nutrition. They're going to have complaints of abdominal pain. They're going to have weight loss. They can have anemia, okay, mainly because all this stuff is going off. I can't absorb nutrients that I need to have. If I'm losing blood through the GI tract, all those things are going to contribute to anemia. If you're having pain, do you want to eat? You just want to kind of roll up and just not do anything. Just give me some pain medicine and leave me alone, which you understand. And then you have to think about if this is happening in a teenager, I have developmental things that go on as well. So there's a myriad of things you got to consider for that patient as part of the reason why we have really strong networks for support. So there are Crohn's and colitis foundations locally that you can actually send patients to do referrals, and then there's national clearinghouses with information that you can provide to patients and their families. Now the other medications that we use for this, we talked about steroids being something you see in common. The other drugs that you see used for this are common drugs too, meaning that they're going to be used to treat on both sides. The cheaper, older ones are what doctors start you on first because you have to fail on those to get the newer, expensive drugs. Just saying. Part of that is because unless you have a disease process that a lot of people have, there's not a whole lot of generics, which is sad, but that's the truth. Sulfazide, which is probably the drug that you're going to see used first on both sides. It is a sulfa drug, decreases inflammation, also has an aspirin component, so yeah, you're giving them steroids, but they have salicylates in there that help decrease the inflammatory response as well. Patients have, remember what we told you about sulfa, got to make sure patients not allergic. Drink a lot of water, because a lot of times patients will tell you, oh, I feel itchy, this kind of thing. It's because they're not taking in enough water. But it's cheap, it's old. You get a whole big old bottle of it. So most of the time, patients have to take 6, 8 pills a day. So that's the other thing. You got to take them before breakfast, before lunch, before dinner. And a lot of times it's 3, 2, 3. So they usually take 8 pills a day when they first start. But it's old and cheap. Okay. The newer ones are not. Mesalamine, which is also a sulfa derivative that you can give to patients. That one is the one that my mom takes that makes me work a second job because it's $900 a month. All right. So depending on what, if I had her pay for that, she reached the donut big time, quick. All right. When you're talking about your other medications that patients take. So that is one that if you are indigent or you don't have insurance, there's an insurance card that will help you pay only $50 a month. Does not apply to Medicare patients. To me, that's crazy, but that's just like, okay, so that's one of those things. But it is something that patients can take. Controls them, usually gets them into remission, because that's what you're trying to do. Get the symptoms under control, achieve remission for the patient. Medications continue even through remission. That's what keeps you there. Okay, so mesalamine is one that you'll see kind of used for patients right now. Asacol is also another drug class. It's the same way. Dosing is still similar to sulfazide, meaning that you're going to take 3 in the morning, 2 in the afternoon, 3 in the evening. That pretty much is for everybody when they first start off with their pills. They may lower their dosages if they get to remission. Okay. Now we're getting into the phase where we're starting to use tissue necrosing factors for these drugs. And so that's what you see on TV. Okay, that's the Humiras, the Remicades, that kind of thing that patients take. That can be IV or PO, because some of them are now PO, that we take for patients. And so those are things that actually decrease the immune response, because that's what's going on with it. Got to give steroids when they're acute, but this is also a drug that you can give, and it decreases the immune response in your patient. Part of what you hear in the commercial when you're talking about using tissue necrosis factor in patients is that you talk about their history of TB, because it lowers your immune response so much that if you have been exposed to TB, you can actually convert to being an active TB patient. Pulmonary tuberculosis is what you worry about. TB can be anywhere, but you worry about somebody becoming positive as pulmonary tuberculosis, because that means you can spread it to other people. Okay, so you have a positive test. The first thing the doctor's going to ask you, you want to go on this drug? I have to treat you for at least 6 to 9 months on anti-TB meds, because you could actually become an active TB patient. Now, of course, you got liver stuff that goes along with that. So you have to look at those things. It's always going to be looking in the context of what's happening with your patient. What are we looking for as far as side effects, symptoms that go along with that. But the tissue necrosing factors are going to decrease inflammation, but also get the disease, hopefully, to achieve remission. And sometimes you'll see that, where the patient's going to take it more frequently, and then we'll go on a monthly dose. So that's the goal of what you're doing with talking about some of those particular drugs. They're very expensive, but if the patient fails on all the other things that have been doing conservative and haven't been able to achieve remission, then you can get those drugs paid for. There's always a process you have to go through. And those are things sometimes that you as a nurse are going to be the person that gives support to the patient. Because they're going like, I need this other thing, I know it's going to work for me, that kind of stuff. But you have to be supportive, yes. Follow the treatment plan that you have so we can get you there. And then provide resources for them. Because a lot of people don't know that there are resources out there. You know, you get a person that's hospitalized and not taking their medications, or they were only taking it for a little while because they know they couldn't afford it. Sometimes they don't know about those medication cards that you can get for somebody. I printed them out in the hospital and give them to patients. Go to the website, print it out for them, give it to them and say, you have to go register on the site, but by doing this, you can get your medication for $50 a month. So yes, it's a little more, if you still have issues as far as paying for stuff, then we need to call case management to see if we can help you that way. Whatever it takes, because it shouldn't be that the person is in the hospital all the time. What you want them to do is be healthy on the outside. Because you all know going to the hospital will kill you. I'm just saying. All right? It's not one of those things you want to do all the time. You want people to do the right things and do what they're supposed to do, because that's the great thing. If people are doing that, that's fantastic. But I also know that if you've been taking these tissue necrosis factors at home, what are you going to be more at risk for in the hospital? You're going to be at risk for developing infection. You're going to be exposed to stuff that's not your normal flora, and the likelihood that you get an infection is going to be greater. So those are not things you actually want to do for the patient. Now the same thing we did about as far as diet, we do the same thing for diverticulitis as we do for these patients. NPO when they're in exacerbation. If they have distension of the abdomen, ileus, those types of things, you might see an NG2 put in the patient. For a Crohn's patient, sometimes they will actually do it under fluoro so they can see whether there's anything in the upper GI tract that's having a problem. Because remember, if you have an area where you actually have inflammation, I'm putting the NG tube down, can actually cause perforation. So those are things that they do under fluoroscopy to make sure nothing is going on with that patient. And there are going to be keys that doctors kind of look for to see if something is happening in that regard. But the reason we also try to get these under control is that when you see this diagnosis, inflammatory bowel disease, put the person more at risk for developing colon cancer or cancers in the GI tract. So if we can try to get these under control, I'm not saying a curative because there's no cure for these right now, except if I have a person who has ulcerative colitis and I take out the whole colon, that person can be cured. Other than that, you're talking about people who have a chronic disorder that has exacerbations and remissions. And what we're doing is making sure they have the tools available to them to kind of help them get better as far as managing their disease, what kind of things they're going to do. And because you put them, you know, all this diarrhea you have, what kind of things am I going to be looking for as far as their assessment? If they have hydration, you're going to look for hydration status because you need to see whether or not they're dehydrated. What other things am I looking at? Skin integrity, because if they keep having all this diarrhea, I actually may have fissures, or I may have hemorrhoids, I may have skin breakdown, especially if they can't get up, they're so weak they can't move. And that weakness we always attribute to people that are older. But think about a kid who might be having 15 stools a day. They're going to be just as weak as somebody who's 70 years old. Okay, so you got to think about that. What lab values do I think I'm going to look at? I'm going to look at their CBC to see whether they're anemic. What else? Your electrolytes, because a lot of things are going to be lost through your GI tract when you're talking about patients having diarrhea. So I'm going to look at their potassium. That's going to be real important to look at. But I also have to look at all the electrolytes because remember, they're not having a good absorption along the GI tract in the first place. Now, of course, if they're dehydrated, what other labs am I going to look at? For a different body system, but it can be affected by that. BUN and creatinine, because I want to see that hydration status. I want to see how their kidneys are working, because that may be something I have to address in this person. Because that's the issue that you worry about. If I don't handle this, I'm going to have complications associated with that. What am I looking at to make sure this person is doing okay? Now, one of the things that might happen, especially if you're talking about the person being NPO for a long period of time, is that we may end up putting this person on TPN. Really big flare-up, they've been in the hospital for a while, and doctors kind of make that evaluation based on patients losing weight. I look at their nutritional status. So I'm going to look at serum protein, serum albumin, pre-albumin levels, because those are things that are going to